classification system based on fracture pattern. First of all, fifth metacarpal neck fracture, also known as boxer fracture, is about 20% of all hand injury. The two most common mechanisms of injury include accidental fall and direct blow. Young population with aggressive contact, and more commonly in males than females. Sorry. About our study, unstable fracture of fifth metacarpal of fifth neck metacarpal boxer fracture, a new classification system by Dr. Kastanis et al. The new classification system is based on fracture pattern. We present the assessment on functional outcome and complication in the surgical treatment of unstable subcapital fracture of the fifth metacarpal. Patient population from January 2013 to December 2019, 123 patients were selected to participate in our study. Male was 112 and female patient was 11, with mean age 29 years old. Preoperative plain radiographs of the hand were obtained for all patients. Patients agreed to participate in the study and signed a full informed written consent. Same orthopedic hand surgeon, Dr. Grigorios Kastanis, at the same hospital, Venizeleio General Hospital of Heraklion, Crete, Greece. Demographics, we talk about hand involved, hand dominance, the injuries, open injuries, bilateral, concomitant fourth metacarpal, and the causes with the most common was punching a hard surface with a clenched fist, about 69.1%. Open fracture classified as grade 1 and grade 2. Criteria. Inclusion criteria, adults more than 18 years old with a traumatic unstable fracture of the fifth metacarpal, less than 10 days from injury, and multiple fracture involving other metacarpals. Exclusion criteria, history of metabolic bone disease, age under 18 years old with fracture of immature bone, old or operated fracture, neurological involvement, and inability to return for follow-up care. About classification system was based in fracture pattern, initial radiographic examination, AP and lateral views with preoperative X-ray and data during surgical procedure findings. We noticed that all fractures did not have the same type in terms of comminution, fracture line, and localization of fracture, and seemed different referring to the neck of fifth metacarpal. We classify all these fractures in three categories based on the fracture pattern: type 1, type 2, type 3. Type 1, the fracture line extends obliquely from dorsal surface of the neck to diaphysis. In dorsal surface, there is comminution and the calcaneus bone disappears, egg cell. In volar surface, there is more integrity. In majority of cases, the fracture patterns also rotational deformity and the volar angulation. In cases where simultaneous fracture of fourth diaphyseal metacarpal exists, the metacarpal neck fracture was type 1. 62 patients in this type of fracture. As you can see here, preoperative X-ray radiographs, AP and lateral views, and during the surgery. Type 2, the fracture line extends more proximally to the diaphysis of metacarpal without significant comminution. In the majority of fractures, there is a volar angulation. The number of patients was 38 patients. Now we can see preoperative X-rays and photo during the surgery. Type 3, oblique fracture. The proximal segment includes the head and neck of fifth metacarpal, shortening of the bone length, and rotational deformity. The number of patients was 23 patients. Preoperative radiographs with the deformity and during the surgery. About surgical treatment, indications. First of all, angulation more than 40 degrees, shortening more than 3 millimeters, rotational deformity or open injuries. All surgery was under regional anesthesia and tourniquet hemostasis control. All fractures were operated with dorso-ulnar approach with prevention of collateral ligament. Open reduction in internal fixation, plates, locking and conventional end screws. About type 1 fractures, 32 patient was rated with blade plate conventional, 30 patient with anatomical locking plate. The plate was applied in ulnar side of metacarpal in 56 cases, and in the rest cases the plate was applied on dorsal side of the bone, 3 screws on the neck area. About type 2 fracture pattern, 12 patient was treated with locking plate in dorsal side of the metacarpal with 2 or 3 locking screw in the head of metacarpal. 11 patient with conventional plate in ulnar side, 9 patient with locking plate in ulnar side, and 6 patient produced a mini osteosynthesis is performed with retrograde intramedullary headless cannulated screws. About type 3, a lag screw and neutralization plate. Here we can see photo from surgery with a plate and screw according to the type of fracture. And postoperative, a palmar split was worn for 5 to 7 days in order to assist soft tissue healing, while passive range of motion exercise of the digit were initiated from the second postoperative day. The suture were removed in 2 weeks, and functional support was applied to protect the fixation until union. In this period, all the patients started a rehabilitation program, which included scar tissue management, edema control, continuous passive movement, self-assisted and active exercise on finger and home exercise program. The median time of fracture union was 5.2 weeks. Results. The total follow-up was 11 months, and especially in 14 days, 30 days, 90 days, 3 months, 6 months, and 12 months. Clinical and radiographic assessment were performed at each follow-up. We assist VAS score, time to return to previous activity, complication rate, X-ray parameters as union angulation shortening, total range of motion, and quick dash score. As we can see here, the range of motion at 12 months, at follow-up of 12 months. Results, mean results, time to union rate was 5 points weak. Quick dash score was 17, VAS score was 13, total range of motion was 239 degrees, grip strength was 92.8%, and time to return was 7.2 weeks. Complication. In 3 patients has an infection, hardware failure mentioned in 2 patients, complex regional pain syndrome in 2 patients, non-union appeared in 1 patient, type 2, shortening and malunion in 2 patients. Finally, volar regulation was presented in 2 patients. Conclusion, it seems that every pattern of this fracture is not the same, and the therapeutic options should be different for the best functional outcomes. Open reduction and internal fixation with low-profile plates offer good functional results, achieving the goal of surgical treatment, which is the full range of motion and the regaining of previous functional mobility. Thank you for your attention.
Thank you, Doctor. Thank you for sharing us your presentation.